A 35-year-old male presents with chronic, progressive swelling and pain in the knee joint. I am showing you a lateral radiograph, sagittal computed tomography, and sagittal proton density and fat saturated magnetic resonance images. Please describe the findings.
The radiograph demonstrates a dense, lobulated joint effusion. The computed tomography and magnetic resonance images reveal a large, lobulated intra-articular soft tissue mass within the suprapatellar bursa and Hoffa's fat pad, with associated marginal subchondral erosions on both sides of the joint.
What is your primary diagnostic concern?
The findings of a lobulated synovial mass causing extrinsic bone erosions, combined with persistent low T1 and T2 signal intensity on magnetic resonance imaging, are diagnostic of diffuse pigmented villonodular synovitis, or PVNS.
What causes the pathognomonic low signal intensity on all magnetic resonance imaging sequences in PVNS?
The low signal intensity is due to extensive deposition of hemosiderin within the hypertrophied synovium, which is secondary to chronic recurrent microhemorrhages.
What specific magnetic resonance imaging sequence can you perform to confirm the presence of hemosiderin through a characteristic artifact?
A gradient echo or susceptibility-weighted sequence will demonstrate susceptibility or blooming artifact, confirming hemosiderin deposition.
Why does PVNS classically cause subchondral bone erosions on both sides of the joint, and what do they mimic?
The high-pressure synovial proliferation causes extrinsic mechanical pressure necrosis, resulting in well-defined subchondral lucencies on both sides of the joint that can mimic subchondral cysts or geodes.
How does PVNS differ from rheumatoid arthritis and amyloid arthropathy on magnetic resonance imaging?
PVNS exhibits pathognomonic low T1 and T2 signal due to hemosiderin. Rheumatoid arthritis and amyloid arthropathy typically show intermediate T1 and low to intermediate T2 signal without blooming.
What is the clinical classification of this disease, and what is its extra-articular equivalent called?
It is classified into localized and diffuse intra-articular forms. The extra-articular equivalent in a tendon sheath is giant cell tumor of the tendon sheath.
Finally, what are your clinical management recommendations?
I recommend referral to an orthopedic oncologic surgeon for total synovectomy. I would also suggest post-operative radiation or systemic therapy if the margins are positive, to minimize the high risk of recurrence associated with the diffuse form.